Welcome back to the Mastering Blood Sugar podcast. This is Dr. Brian Mowll, and with me here today is Dr. Tina Moore. Tina is someone I've known for quite a while, but I'm really excited for this conversation because we're going to talk all about GLP-1 receptor agonist, GLP-1 hormone, other signaling hormones or peptides in the body, and how all of this relates to metabolic health. And specifically, Dr. Tina's journey using GLP-1 receptor agonist peptides, and maybe how some things that we can glean from her experience and what she does with her patients now. That's a little bit different, I think, than what we're seeing in mainstream medicine. So, Doc, welcome. Glad to have you here.
Thank you. I'm so excited to be here. It's fun to connect finally and get to chat with you.
Definitely. So, this topic is hot right now, and we're seeing the use of these medications. We're seeing the creation of new medications with, GLP-1 receptor agonists in them or associated with them, skyrocketing. And they are effective for sure. I mean, we see people losing all sorts of weight. But on the other hand, there are some scary headlines and people reporting pretty disastrous side effects. So I'd love to dive into this topic with you and get your perspective.
Yeah, sure. So, well, like you, I was hesitant a little bit because I was hearing the headlines, and I won't speak on anything unless I research it myself or have some experience with it personally and professionally. And so my podcast producer actually was the one who kept saying, let's do an episode about this. And I was like, well, I feel like I'm hearing a lot of people throwing it under the bus. And whenever a lot of people start parroting the same thing and I hear the same words coming out of people's mouths, I usually raise an ear that reeks of propaganda to me. And so I started looking into it, and I found other doctors talking about it like it was, they, like you, were specializing in diabetes and blood sugar, and or maybe they had obesity clinics, and they were having profound results. And I was like, okay. So I looked deeper, and so I'm a chiropractor and I'm a naturopathic physician, and my entire practice I'm no longer seeing patients. I have a few that I still work with, but my entire practice was regenerative injection therapy. So I was in that regenerative medicine world long before it was cool, long before people were throwing around the term stem cell. I was doing a lot of injections way back in the day, and I always keep my ear to anything regenerative. And so I started looking up GLP-1 agonists and found out the data goes back some 20 years. They've been using these in practice clinically for 20 years, and they've been around since the 90s actually, but they weren't put to use until the early 2000s. And there was absolutely no fanfare or horrific headlines until the past two, when the topic of weight loss came up. And that made me raise my eyebrow even more. And I was like, that tells me a lot about how society views things. I mean, this has been a really interesting journey for me posting. I have a fairly large online presence, and even posting about it there, I've gotten a lot of feedback, good and bad. And it's been really interesting to see the sort of bias and stigma around obesity and the way obesity is handled. But all that to say, for 18 years, nobody was saying boo. People were not having horrific side effects. There weren't all these big clickbait headlines. The influencers weren't all screaming about how awful it was. And I was like, this is very interesting. I started looking into it as a regenerative peptide, and it is a peptide. It's a hormone. It's a hormone signaling peptide. And a lot of people don't realize that. It is only very slightly different than the naturally occurring GLP-1 that our bodies should make. And it's naturally occurring GLP-1 it has a short half-life, so it gets used up quickly in the body. The way that this has been tinkered with is that it stays longer. That's it. But it's essentially identical to our naturally occurring GLP-1 in most cases, when you're looking at just the straight GLP-1 agonists. And there's a whole bunch of them. There's like at least half a dozen of different ones that have been in use, either mostly injections, some oral, and there's a variety of them on the market that have been used safely for type 2 diabetes. But I started looking at the regenerative impacts, and the first thing I found was about the brain and the neuroregenerative impacts that these peptides have. And you know, and I know, but I don't think the audience knows, regenerating neurons in the brain is unheard of. I mean, that's just something that doesn't happen. And so I was floored, honestly. And then the anti-inflammatory impacts in the brain and what it does to calm and quell the glial cells in the brain. And I was like, holy smokes. I mean, I remember my jaw dropping and me turning my phone around to my husband who was cooking, and he just listens to me babble on. he doesn't, I don't know how much of it he takes in. And I was like, oh my God, like, I can't believe what these peptides do. This is not at all what I'm hearing. Right. And we can address the big scaries that we're hearing about in a second, but all that to say, that immediately perked up my brain around, I wonder what its impact is on pain, because if you can quell inflammation in the brain downstream, you're going to have an impact on pain, because pain is, in essence, a central, nervous system issue. Chronic pain, especially. It's not so much in the tissues as it is actually centrally in the brain. And I suffer from chronic pain, and I have psoriatic arthritis. So of course I was like, I wonder what it does to the immune system. Turns out it has a major impact on the immune system. Most of the organs in our body that I've found have GLP-1 receptors, and our brain has GLP-1 receptors, and it's not only made in the gut, and it's not only a gut hormone, it's actually a brain hormone, because we have regions of our brain that actually make it. And so it must be important if it's being synthesized in the brain and utilized in the brain beyond appetite control. And it turns out that it does have an immunomodulatory effect. And downstream, it binds to our immune cells, which I think is amazing. And then I found a study showing that there was a 14% reduced risk of pneumonia with upper respiratory infections. And I was like, that makes me wonder why they don't want it out there. And then I found the studies on the cardiovascular benefits and the pancreatic benefits. And it, in truth, reverses insulin resistance and reverses the metabolic dysfunction that so many Americans are dealing with. Probably upwards to, I would say, close to 100% of US adults have some kind of metabolic dysfunction. And so on is really how I got into it. And I thought, this is not at all what I'm hearing. Why are we hearing what we're hearing on the media, and everybody's so scared of it and they're vilifying it? And yet I'm finding piles and piles of data going back 20 years showing all of these amazing implications. The musculoskeletal system inside our joints, our muscles, it does not induce muscle loss. It actually induces muscle protein synthesis directly and by signaling pathways. It plays with our appetite hormones and works in concert with them. And without them, we don't get proper appetite or satiety signaling at all. And so anyway, that's what I've been sort of engrossed in the past several months. And I've nerded out on it, and we're not getting the whole story in a nutshell.
Yeah, clearly. So before we dive into some of the, potential adverse effects, I'd love to talk more about the positive benefits. You talked about appetite hormones. So, GLP-1 itself certainly has an effect on appetite, acts on the brain. It also has an effect on blood sugar through insulin and glucagon. It has an effect on gastric emptying, which in turn can obviously affect appetite as well. But it does a lot more. So can you, you've shared some of the regenerative properties. You talked a bit about muscle loss, which I'd like to get more into, but just from an appetite, peptide or hormone perspective, what are some of the sort of more expanded benefits or effects of GLP-1?
Sure. So we have several signaling hormone peptides that are involved in our appetite. And without getting into all of them, because it gets messy, and I don't even understand. I don't think anyone actually understands all of them, right? We're just, it's the tip of the iceberg. And this was discovered in the 90s, leptin being a big one. And we really, interestingly, there's a book called, I can't remember the title of it, but it's all about fat. And it's the story of fat, basically. Mm-hmm. And every single time there was a remarkable discovery in the world of obesity medicine, it got shut down. It got shut down or pushed aside, or the articles, the clinical studies wouldn't be published. They were like, no, this can't possibly be, so we're just going to shut it down. It's crazy to watch the history of it. So this, like many others in the 90s, people were like, man, leptin. Well, leptin is pretty damn important, and I think a lot of folks are starting to give it the credit it deserves, but it is the hormone that is secreted by your fat, and it is responsible for letting the body know what the energy storage situation is in the body. And the fat secretes the leptin goes to the brain. Leptin actually sits on a couple different organ systems, but mainly it goes to the brain that we understand, and it tells the brain you're full. You have enough energy in the system. When people lose fat, they actually lose leptin, which impacts their appetite. It actually makes their appetite go up. It's the weight loss part of things is the easy part, though. Sustaining of the weight loss is very difficult, and leptin is a big player there. The other hormone that's important is ghrelin. Ghrelin's secreted by our stomachs, and ghrelin, I think, that's how I remember how it works. Ghrelin tells you you're hungry. So mechanically, when there's not a load of food in the gut, the ghrelin gets released, it goes to the brain, it tells the brain it's hungry. So I think of leptin and ghrelin sort of as opposites, right? You mentioned insulin. Insulin's a signaling hormone. It's secreted by the pancreas. It lowers blood sugar. Glucagon is also secreted by the pancreas. It raises blood sugar. So all of these hormones work in concert. Sometimes they work opposite each other, but they all work to me like a big symphony. And when one is off, they're all going to be thrown off. And I think that's the appreciation that so few scientists or practitioners have. Everybody wants to push a pathway or stop a pathway, and they don't realize that the beauty is really harmonizing and getting homeostasis intact, right? And you know that, but a lot of doctors are like, oh, this is bad and this is good. That's not how it works. None of these work right or even signal appropriately without GLP-1. And that's when I started wondering, I wonder if GLP-1 deficiency is a thing, because my practice was regenerative medicine, but I did a ton of bioidentical hormone replacement as well. And I thought, I wonder what physiologic doses of GLP-1 are. I wonder if they're too low in people. And turns out we've got data to show that those struggling with obesity, insulin resistance, and diabetes are in fact GLP-1 deficient pretty significantly. And I thought, well, I'll be darned. That's most of society these days. I wonder if GLP-1 deficiency is not only are we dealing with where it's made, so I mentioned the brain, but the L cells of the gut are where the majority of it is secreted. A lot of people have gastrointestinal issues. They might have inflammatory bowel disease or irritable bowel syndrome. We know that people have bad guts. We know that people have leaky guts, right? Like that's across the board. We've known that for decades. So I got to thinking, well, maybe they're not synthesizing it correctly. But then I got to thinking, I wonder how deep this goes, like to what layer. And you mentioned genetics. So that is fascinating to me if you want to talk about that in a second. All that to say, it got me wondering if we replaced physiologic doses of GLP-1, not these supraphysiologic doses like we're seeing in the brand names and the standard of care, the way that it's being done at large, which I completely see the problem there. I see why people are having horrific side effects. I don't think that is being done right at all. That's a long conversation, but I do believe that there is a place for low doses of GLP-1 and that supraphysiologic supplementation. It would be like if we had a thyroid patient who had subpar thyroid functioning, even maybe their labs are normal, but they've got all the symptoms. I always go ahead and prescribe thyroid hormone in those cases. I always give them a little bit of a leg up, and it can be miraculous and life-changing. And while a traditional MD might look at labs and say, oh, there's nothing here, this patient doesn't need anything, the patient's struggling and suffering tremendously, we give them just the tiniest bit of thyroid, micro doses, in fact, and their whole world changes. So to me, that's what I clinically got to thinking about with GLP-1s. That's how I started treating my patients. That's how I started treating myself and my family members. And the results have been mind-blowing, like just mind-blowing. And all of them were put on GLP-1s for reasons outside of weight loss. The benefits of these peptides are so vast, and there's a laundry list we could go through. And those are all independent of weight loss. Sure, weight loss helps, but the actual mechanistics are independent of weight loss. And that's the part that's being completely missed in this story.
So interesting. Yeah. You started off talking about a little bit about the history of the medications and what we've known about this hormone. And I remember, I've been doing diabetes care for a long time, and there were these drugs. There was exenatide, which was out years ago, Byetta, and then Bydureon, which was the long-acting version of that. And these drugs really were not blockbuster drugs. I mean, they were interesting. They weren't used all that much. Eventually, they became known as drugs that lowered blood sugar a little bit, but their main effect was appetite suppression, would help people lose weight. And I don't know how true this is, but I remember hearing that the first, exenatide was formulated from some chemical found in the Gila monster saliva. I don't know how true that is, but
I don't think it's true. But I think that's how it was discovered. There is a Gila monster somewhere in this story, but I hear what you're saying.
Story behind it, but
I
it always
into
made
that
me laugh thinking about that. But then, the next generation of these medications started to lower blood sugar more, and they started having more potent weight loss benefits. And so, now we've seen them added to other medications, changed a little bit. So when you look at the newest of these, there's semaglutide, which I think is what you've used. There's tirzepatide, which also includes GIP or GIP. Mm-hmm. And then there's some new medications coming down the pike that include amylin, for example, which is another hunger hormone. So how do you look at all this? And this is going to be a complicated question, and then how do you weigh out the benefits of compounding something like semaglutide with the sort of pharmaceutical products that are available?
That is a really important part of this story. Okay. The brand name drugs that are owned by, from what I understand, there's two big pharma companies that own the brand names, the Ozempic, the Wegovy, the Mounjaro, et cetera.
Right.
Those come in pre-filled pens that have a certain dispensing amount. So the strength of the dose you're going to get is predetermined by the pen, and you cannot change it. So you have to start at whatever that starting dose is.
Okay.
I believe that starting dose to be significantly too high. Way too high for most people. And I can't tell you how much it's too high because it really depends on the person, and it depends on what your goals are for the person. So for myself, I started taking tiny, tiny doses because I have chronic pain, I have psoriatic arthritis, and I wanted to get those two things in check first and foremost. I was also dealing with some tremendous brain fog that was induced by chronic stress, perimenopausal. I'm 50 years old and I'm doing pretty good for 50, but I still was I was feeling it, and then post COVID, I definitely had some brain fog. So I was using it for those reasons primarily. The weight loss that came with it was a nice bonus, but all it did was get me down to my fighting weight, which was my 2019 weight before all the stress started. So I really didn't go into some extreme skinny world, and I really wasn't interested in that. That's not how I dosed it. I put my mother on a different dose. She's got Crohn's disease. She's in her 80s. It completely stopped all of her chronic joint pain that was related to the Crohn's disease and has significantly improved her gut function. My dad is morbidly obese and severely diabetic, and we've got him on a different dose, and we're ramping up his dose differently because we're trying to actually we're using it more traditionally that you would with these brand names. But he's still on a tiny little dose compared to what the brand names offer. And I'm seeing this with patients across the board. And then I've got other colleagues utilizing these peptides at tiny low doses, which you can only get if you compound it. You can only get that option available if you compound it. And they're using it for like SIRS in relationship to mold illness. They're using it for Lyme disease. They're using it for, all varieties of things that are independent of weight loss, and people are having really phenomenal effects. And a lot of these folks were presenting with blood sugar dysregulation. My labs look perfect, but I was definitely showing signs of insulin resistance. It was apparent to me. I don't think a doctor would have caught it. Even my own colleagues were like, "Oh, you look great." I'm like, "I look great, but something's wrong." Like I could feel the beginning stages of insulin resistance.
Yeah.
And as well as I do that And they know this in obesity medicine. The best solution to obesity is to never gain the weight in the first place. Every time you gain and lose, you're now looking at, I mean, your brain rewires, everything changes, and you're now looking at a more uphill struggle from that point forward. And it's very hard to reset that. So, and I don't know the solution to that. So for me, it was like, I put on 20 pounds, virtually overnight. That is a signal something is wrong. And I've always felt that to be true in my clinical practice. When a woman, especially a woman, comes in around menopause and says, I just put on 15, 20 pounds, I'm like, we got to stop this before it goes too far, because it's going to be another 10 or 20 in another decade or even a few years. And I listen to that very seriously. I take that seriously. And so that's another intervention, but that's somewhat immunologic. It's hormones. It's varied. So anyway, the brand names I think are too high. I think people are being dosed too high from the start, and I think they're being ramped up way too quickly. I have found that over time, these really seem to be healing the metabolism, and with that comes a balancing of weight, and it takes time. So I actually am keeping people on the same dose for 3 to 6 months without barely even ramping them up. And in some cases, I take them down. I'm cycling it just like you would a hormone. You get off of it, you get back on. You get off of it, you get back on. That's going to be different for everyone, what that cycle looks like. For me, I go about 14 days and my psoriasis starts coming back and my pain starts coming back.
Interesting.
So, whatever that cycle looks like, but with hormones, we call it a hormone vacation, right? Whether it's 1 week a month or 2 weeks or, so the time on and the time off and the dose is going to be different for everyone. And that's why you really need to work with a physician intimately who is comfortable working, at a high touch functional medicine type of practitioner. But that's really the difference. And so these folks are being, on the brand names, are being dosed at crazy high doses. Their receptors are being saturated. So they're going to run into GLP-1 resistance very quickly, just like you would with any hormone. That's a problem. So the sustainability of that strategy is just, they're going to hit a wall. And then there's management and dosage, and that's on the doctor's part. And then there's compliance, which is on the patient's part. And we know that most patients it's very difficult to get them to strength train. So they're not protecting their muscle, and any weight loss from a caloric restriction or a low calorie diet is going to induce 20 to 30% lean muscle mass loss. Any strategy that's low calorie is going to do that. It's not the semaglutide or the tirzepatide or the GLP-1. It's the actual caloric restriction. And so we want to offset that by protecting the muscle. So we have to prioritize our protein intake and we have to strength train. And we know that that's difficult to get patients to do. It can be challenging for them. There might be some restrictions with time or finances or what have you, And so that's why people are having horrendous weight loss. And the real problem with these high doses is that people are cranked up on them. They're already metabolically brittle. They're cranked up on super high doses. And now they're in worse shape because often the insurance coverage runs out. The dose is so high that the medication stops working because they've saturated their receptors, and now the receptors are cleaving off and we've got GLP-1 resistance. And on top of that, they've just lost a good percentage of their muscle mass. So now they're more metabolically busted and brittle than they were when they started. And all the weight gain comes back on, and it's a disaster. So I can see why in the mainstream media, this looks, from an onlooker's point of view, this looks like a total disaster, which it is in many cases, but there's a way to do it right. And that's what's not being talked about.
All right. So this is the wrong way to do it. And this is probably where most of the adverse events come from, because if you've already got, let's say, normal GLP production, but you're maybe a bit GLP-1 resistant, and then you add a bunch, you add a high amount of exogenous GLP through the medication, now you've got pretty high levels, and you can see how that could go from slowing, gastric emptying to paralyzing the stomach, in some cases, or leading to very, very serious side effects, constant nausea or vomiting and that kind of thing. These are the horror stories you hear. But, I think these are most likely from people taking too much of the medication for their body.
Yeah.
We can't say that for sure, but that's my suspicion.
Well, none of my patients are having any side effects. And the only time I've had any personally was when I ramped the dose up too high. It builds up in the body. So that's why I say letting that dose sort of percolate for an extended period of time is helpful, but it's about, everyone I've talked to who uses these quite a bit in practice, they'll all say the same thing. It's about month 2 to 2.5 when the weight really starts coming off. Mm-hmm. It's also when they start running into terrible side effects. Well, that and if they start them too high, of course, which, right now, Ozempic, the starting pen dose is 0.5 milligrams. I start people at a 1/10 of that. I mean, it's just crazy what they're starting. I think it would kill somebody. I'm like, how are people getting away with this? That is a horrendous dose. My dad's doctor wanted to put him on 0.5. And I was like, are you kidding me? I think I had him on 0.1 at the time. It's like, we got to go slow and low with this. That is like taking somebody and overdosing them on thyroid medication, and they have a heart attack because we gave them tachycardia from too much thyroid, and then we blame the thyroid hormone. Like that to me is what's happening here. It's crazy. It's like if we gave somebody too much of any medication and they had a horrendous side effect profile, and we're like, oh, the peptide's evil, the medication's evil. It's like, no, you just overdose them. Clearly. So even if they have a deficiency, we only want to supplement physiologic levels. We don't want to overdose that. So I microdose testosterone, I microdose estrogen, progesterone. Not everybody can handle the standard dose. I mean, we have these algorithms of like, okay, the lab should look like this, and then we dose this much. I've never found that to be accurate. I'm always a slow and low girl. I microdose Prozac in patients. A dose of something at a very low dose has a different mechanism of action oftentimes than a high dose. And so the gastroparesis, for instance, who gets gastroparesis? Diabetics. Right? They're already sitting with the vagal nerve damage. They're already sitting with gastroparesis. They don't know it. They're just saying, oh, I have bad digestion, doc. I'm burping and I don't digest well. I'm like, no, you have gastroparesis because your vagus nerve has been destroyed by high blood sugars for extended periods of time. So you take that group and then you throw something at them at way too high a dose. It's absolutely no wonder why people are ending up in a pickle, and gastroparesis is not permanent, by the way. That's the other part of the story that people are not getting. I mean, I suppose if you have such severe diabetes that you have destroyed your vagus nerve completely, then yes, it might be. But in a normal individual, that is just a temporary induction of a problem that will resolve itself as the peptide works its way out of the body.
Interesting.
It's been really sensationalized, The pancreatitis issue, the SPECT trial, that was a cardiovascular trial that showed really great efficacy with reducing cardiovascular disease in those who were not diabetic, but were overweight and over 40 or 45, I think. So, kind of that middle-aged age group. But one of the interesting findings on that, it was a big study. One of the interesting findings was pancreatitis was less in the group that was on semaglutide than in the control group. The control group had more pancreatitis. The pancreatitis issue is a misnomer. There's no pancreatic cancer, by the way. I don't know why we keep hearing that. I keep seeing it all over the internet. There is no conclusive evidence at all that is pointing it to a causative effect of having pancreatic cancer.
Pancreatic cancer.
I don't even see correlative studies. Like there's that. I don't even know where that conversation's coming from. But all that to say, that's because you take somebody who has sluggish digestion because they've been rocking high blood sugars. Those who are dealing with obesity and diabetes tend to have gastrointestinal issues and sluggish digestion, as we just spoke about. But you take that group and maybe you don't counsel them to change their eating habits, and maybe they're pounding high fat, high ultra processed carb food, and maybe it's bad fats, maybe it's like, and I'm not trying to, throw everybody in the same category, but I've seen this and I've heard about this directly. I have a lot of followers. I've gotten a lot of stories. They're still trying to crush a couple Chick-fil-A's while they're on the peptide. Their gastric emptying has been slowed down. Their peristalsis has been slowed down. Usually their gallbladder's a little sluggish. Now they're in a severely calorically restricted state because the dose of the peptide was so high that it crushed their appetite. So what happens when you take a body that's already compromised and then you slow down digestion and you slow down caloric intake, the gallbladder starts forming stones because the bile thickens. So then you throw a stone, and the number one cause of pancreatitis is gallstones. And it happens more in obese and diabetic folks. So like, we're looking at a group of people who are already on the edge of a potential problem, and then they're getting slammed with super high doses of a peptide that I think is an overdose, and you see the problem.
Okay, so a couple lessons to take away. Whether you're doing compounded or not, take it slow on the dosage, right? So many people listening to this are going to be diabetic or using it from a diabetic perspective. There will definitely be some who are using it from a weight loss perspective or considering that. So whatever the case, you don't need to increase the dose every 2 weeks or 4 weeks, right? I mean, this could be maybe, even if you're starting on 0.25 of Wegovy or 0.5 of Ozempic, you can stay there for a while, and give it a chance. Maybe you're going to see benefits after 2 months or 3 months, rather than, because I think people in general are looking for, like, they want their appetite just totally crushed. They're looking for that huge effect, and they've heard that, your appetite just totally goes away, and they're prepared for all these side effects, or at least some of the the more common mild side effects. And if they don't experience them, and if they've still got, their appetite a bit, they may feel like, oh, I need more.
Right. Right. And I think that's exactly what happens. And then I think people start ramping it up and they get into trouble. Because like I said, it builds up in the system, it seems to. And the folks that I know that are using it as part of the doctors that are using it as part of a comprehensive program, this is not a good idea to use as a monotherapy. Using just cranking Ozempic and hoping for the best is a terrible idea for many of the reasons I just explained. But more importantly, you need your hormones dialed in. You need your gut health dialed in. It has to be a functional, comprehensive approach because it doesn't work in isolation. There was just a study published that came out. It looked at women. It was a small group. It was 90 women who were not on hormone replacement therapy and 16 who were on hormone replacement therapy. And they were all given semaglutide. And the ones on hormone replacement therapy lost 30% more weight. So having your hormones dialed in is critical, right? So usually when we're looking at new patients, there's a lot of work to be done. And while these peptides are a wonderful tool as part of a comprehensive tool belt, they are not the solo solution. And that's another reason why I think the traditional medical system is failing, is because they're using, not everyone, I know there's a lot of good docs out there who are in the more traditional system, but most docs are cranking the peptide. And the reason being is dosage is determined by the studies, and the studies cranked the peptide. I mean, I don't have a better explanation for it. The study started people too high and it moves them up pretty high. And that makes no sense to me. It's like, but that's what MDs have to follow the standard of care. And that's what the standard of care now is. So, and that's how the pens come. So it's a lot of this isn't the doctor's fault. It's just the way that it's been set up and the way that it's working out. So doing a compounded version, slow and low, giving your body time to adapt whilst implementing all these other wonderful behavioral and lifestyle changes that are critical and necessary, and addressing all the other things that are going on. This peptide, I wouldn't say wait on it. It works really well to help modulate the immune system, help regenerate tissues, help heal tissues. It's anti-inflammatory all over the body. So I think that while it's doing its work, the other strategies can come into play because it does crush the hedonic urge, and it does give people a lot more sense of control. And that control will percolate out into the other lifestyle changes. So people who maybe are hesitant to exercise, they eventually will want to start. It gets people moving. I have gotten so many hundreds of messages from my followers who either started after I produced a series of podcasts on it or who are now starting. And all of them say the same thing. It really got me moving, doc. Like, I feel like I can actually do all the things I wanted to do. I was just held up because of excess weight, or I was held up because of excess pain, or I was held up for whatever reasons. Even the rumination, people are, it's being studied right now for addictive behavior. So alcohol abuse syndrome, it crushes the desire to drink, which is super cool. Smoking cessation, addictive shopping, anything where people are like chasing the dopamine dragon,
Right.
really cool impacts there. We don't totally understand how or why. We know it impacts the hypothalamic pituitary axis. So we're learning, but the implications of this are so vast and far reaching, again, independent of weight loss. But I will say that's kind of a nice cherry on top is people start to shed that excess fluff. It gets them moving. For me, my pain was reduced. And so I was able to go back to a lot of the things that I was used to doing. My activity level skyrocketed once I went on tiny little doses of it. My mom's able to work all day in the yard without coming in and crippling joint pain. I mean, there's just so many cool stories that I share their stories because they've allowed me to, but that's really the thing. We have to treat this comprehensively. You know, the diabetes doesn't happen in a silo. And I really do think that implementing these peptides earlier than later is a really solid strategy, because why are we waiting until people are so far gone? And by the time someone has type 2 diabetes, and I say this with love, but their metabolism is trashed, right? Like they're really in a pickle. This is a lot of pathologic changes have happened in their bodies for a long period of time by the time they get there. I'm over here having a different conversation saying, why aren't we implementing this peptide early when we actually could offset all of that from occurring? Because people are headed that way. Point. Or not, you know, if in 2018 data showed that 94% of US adults had busted cardiometabolic health, all of those people are headed to type 2 diabetes. I say stop it early.
Hormone replacement is a lot different than medication that's used to like manipulate the body in some way, right? So certain medications, and I'm not saying that I'm not saying one is better or, you know, that these medications are not good or can't be helpful, but certain medications are there to suppress the body's natural process or manipulate it in some way, right? Like you take an NSAID to reduce inflammation. Right. That's there for a reason. Okay. So maybe it's useful, but it's working sort of against the body's natural processes. Hormone replacement, I look at as very different. So, you know, if somebody has low thyroid and they've tried some natural things to boost thyroid activity and it's not working, replace the thyroid hormone. You know, if somebody has low estrogen, replace the estrogen. Low testosterone, replace the testosterone. If a type 1 diabetic has not making insulin, give them insulin. And what we see with GLP-1, is that certainly most people with diabetes don't make enough GLP-1. And I don't think we have the studies yet, but you and I were talking a little bit before we started recording that there's a good likelihood that people who struggle with weight or maybe over their lifetime have started to struggle with their weight are seeing GLP-1 levels drop also. And there's genetic factors for that. You know, possibly it's just physiology too. So whatever the reason, replacing that hormone can just get the body back in balance, back to a place of functioning the way it's supposed to. But like you said, it doesn't necessarily have to be in these large doses. We may not need that much.
Yeah,
so
I agree.
Let's talk a little bit about, unless you want to lean into that a bit, let's talk a little bit about compounding, because there are doctors who rail against compounding. There are articles about counterfeit semaglutide out there, and, you know, don't buy from a, you know, from a source. There are articles that say there's no such thing as compounded semaglutide, that the only place you can get it is as a branded product. So can you talk about all those issues?
Absolutely. First, I do want to back up for a second, because you said something that was really important, you know, replacing the hormone. When people say, well, I have to be on these forever, that's a big question I get. Well, I have to be on them forever. My question is, would you ever want to go off your estrogen? Would you ever want to go off your thyroid? Because I certainly don't. So I do plan on being on these forever. And that's why I prefer to keep the dose as low as humanly possible, just like I do with all other hormones, so that we can have them be successful for the long term. so that we don't get the body too acclimated to them. And that's why we cycle them. So yes, you may need to be on them forever. And people with really severe metabolic dysfunction and very severe diabetes may need to be on them forever. But I think done right, that's not a problem. That should not be a problem. And then the other thing is that no one's talking about, and we don't have to get into it too far, but I've done a lot of research into maternal obesity and maternal diabetes and the impact on the offspring. And it's terrible. It's terrible. And these children are epigenetically programmed for almost certain obesity and diabetes down the line for themselves, and for their offspring. So that's something that we don't talk about because it's a really uncomfortable conversation to have. And we are a couple generations into that now. So that's where I do feel strongly that intervening early when somebody's metabolism starts to go off the rails at whatever age that is at, that we consider intervening. It's a very similar conversation to, do you give a child thyroid replacement? I say absolutely yes, because you're impacting their IQ. I mean, their IQ is going to be significantly less if they don't get the thyroid when they're a child, but a lot of children don't get treated appropriately when they need to be. And I think it's leading to a lot of low IQs, a lot of behavioral issues, a lot of depression, a lot of issues down the line. So that, I just wanted to say that because I look at it very much the same way as I do a hormone. And that's what I think about hormones. So anyway, compounded. I don't know why they're railing against it. I've been using compounded medications for my patients for decades with great success, and there's never been any issues. I get injectables compounded, I get pills compounded, I get creams compounded. Everything's great. The FDA has been really pushing doctors to be afraid of compounding pharmacies and compounded medication. And when I look at I always open them and I read them all. And every time I do, they start with, some clickbaity title about how dangerous compounded semaglutide is. And then they go into the counterfeit versions and how people are getting them randomly off the internet. And then at the very bottom, there's usually some blurb about, or some quote from someone saying, well, we haven't actually had any real problems with the compounded versions, but... You know what I mean? It's like this same storyline throughout every article. I have several compounding pharmacist friends, and I've asked them, and they're like, there's no problems. We're seeing absolutely no problems. The reason they're allowed to be compounded is because there's a shortage. And so because of that, and there's actually not a shortage on the semaglutide, there's a shortage on the pens. It's the dispensing pens they're having a shortage on. You'd think they'd be able to resolve that, but they're not. So I don't know. Don't quote me, but from what I've researched, that's what I found. Maybe it's changed in the past few months. The compounded version is allowed to be made and dispensed through a compounding pharmacy because there's a shortage of the regular brand name medication. And I think the problem that is happening, if there is any, it's not the actual product. It's that you pull it up into a syringe yourself as a patient. You just, you decide what the dose is and you inject the dose, and there's user error and people are overdosing themselves accidentally or taking too much, or maybe, like you said, people want a quick fix. And so maybe people are double dosing. Who knows? I've heard and read so many different versions of this, but people are definitely having problems with the compounded, and it's user error. It's not that the product is in any way, shape, or form dangerous or not high quality. So it's not that. And then the counterfeit versions, I don't know. I mean, there's research companies that you can buy these peptides online. I would never tell somebody to go do that. I'm licensed to prescribe. I cannot even tell somebody to go take peptides that way. But who knows where people are getting it? It's just all getting clumped into the same conversation. And it makes me wonder, the pharmaceutical companies who own the patents on these, how much are they involved, right? How much are they really controlling this conversation? Because they don't want people taking the compounded version, because the compounded version is significantly less money than the brand name version. So, and then the doctors, I just read an article the other day. It was an interview with several obesity doctors, and they were all vehemently against it. They were like, I will never use compounded. And then their license is on the line if they do, because depending on the state that they're in and what their licensing board is like, doctors like to witch hunt each other. And most complaints to a board are from other colleagues in your profession, right? And so I've had many doctors say, I'm just not comfortable using compounded because it's my license on the line. I don't want to get in trouble. If the patient has a bad outcome, they're afraid they're going to lose their license or they're going to get sued. So this whole thing has just turned into a big, unnecessarily dramatic storyline.
Yeah, that makes sense. The dosing is not that difficult though, and you're using an insulin pen, basically a very, small needle. So it's from I've never done it, but from what I understand, it's not painful and it's not really difficult to draw
No.
the medication and so forth. I think it just takes a little bit of practice probably, and make sure you're paying attention the first few times you do it, especially.
And keeping track. Oh, sorry, I don't mean to interrupt, but keeping track.
Okay.
Like I actually keep a journal. And the one time I got in trouble, I gave myself a dose 3 days too early. And I gave myself the tiniest little bit too much. So, it can happen. I'm a physician. My whole practice was pulling up syringes and injecting people with stuff. I'm pretty good at it. And so I even, when you're doing tiny doses, or maybe you're elderly and you can't see the lines on the insulin syringe so well. So there's just different little reasons why you might just get a little touch too much. And I did get a little gastrointestinal disruption and I was fine. The other thing that I didn't talk about, I just want to quickly say, is the GLP-1s have been shown to shift the microbiome in the gut to a more favorable, less pathologic biome. But I think in that shift, we're probably seeing a lot of die-off reactions, and we're probably seeing a lot of Herxheimer reactions in patients. So as their biome is shifting and the pathologic bugs are dying away and the good bugs are taking over, I could see, especially if that happens too quickly at too high a dose, that could be really uncomfortable for people. So that might be part of the gastrointestinal side effects we're seeing. It's not necessarily the peptides impact directly as far as slowing down gastric emptying, but more on the side of like their gut was a wreck to start with and we just shifted things around. Or maybe they go into it with SIBO and the slowing of the gastro, the peristalsis might make the SIBO rear its ugly head. There's lots of things that's why I say preparation is key and really working with somebody who can treat you comprehensively.
Yeah, that makes a lot of sense. And so on the other side, some of the benefits are obviously you can modify the dose, and this is really critical for what you're talking about because you may want to start at a much smaller dose. So the Ozempic starts at 500 micrograms. You're talking about using something like 100 micrograms or 50 micrograms even as a starting dose.
Maybe.
Okay.
It depends. And I found that people who are more metabolically optimized don't need nearly as much. Men seem to have a different response than women. I've noticed women to be more sensitive to it than men. I don't know why. Maybe it's because we have more body fat, and when we're injecting it, the way that it dissolves through our, and gets distributed through our body via the fat. I don't know. I'm just seeing it kind of across the board. So that starting dose really varies. And I gauge it on the person's overall health, their overall metabolic health. Do they have any gastrointestinal issues to start with? That's why a really comprehensive workup I think is important. Working with somebody who can treat you on all your systems and not just, that monotherapy, like we're just treating your diabetes, which we know is, I know, but for the listeners, there's so much more to this than just gunning down your diabetes, right? We have to look at you as an individual and what are all of the systems that might be a little out of whack, and then making sure we support all those systems concurrently, right? Like supporting digestion, supporting liver health, supporting, I think there's probably a very detox reaction that's happening if people are losing fat too quickly because we sequester all of our toxins into our fat. And so my mom is a hairstylist. I really don't want her to lose weight too fast, right? I don't want those toxins coming out quickly when in her little elderly Crohn's disease body. I want to make sure we take that really slow and support her along the way with sauna and with some liver support and, so on and so forth. So there's just a lot. And I think that's the case with any weight loss. Back when I started my practice in the early 2000s, HCG was all the rage. And so we were doing a lot of that. And there's really a lot that goes into the patient care beyond the GLP-1, right? And so that's where I think it's such a wonderful adjunctive tool, but it's not the solo. It's not the only big gun.
Yeah. I also wanted to quickly ask you about, I've seen sublingual semaglutide now being promoted online. I don't know if you've seen it.
Yeah.
Have you had any experience with that? Do you think it works, or could it be as effective?
My good friend is a compounding pharmacist, and he just started dispensing that in his clinic or in his pharmacy. And he said they're seeing great results and that people are having very low side effects because, again, you can play with a dose, right? So anything you can play with the dose with. The needle itself, though, is so simple and easy. And so I feel like when we're talking sublingual, we're going to have a varied absorption depending on the person. And that's where things start to get a little less standardized for my comfort. I like needles. That's what I did in my clinical practice forever, was everything was needles. So I like needles. It gets it done faster, and we know what we're injecting and we know how much it is. That can vary by body fat storage and where the person injects, though. So there is, different variables there. But yeah, I think sublingual seems to be an exciting new option. I talked to some longevity docs, and they're telling me that either the oral or the sublingual, they're not seeing as good of results. But they also, everyone I've talked to is starting people at the standard starting dose or close to it, very close to it. And I'm talking a different story. Like I said, I'm talking tinier doses. So I think anything where we can play with the dose and the patient is comfortable doing it. The other problem I have with sublingual is, what if you give yourself one drop too much, right? Like it really can be the difference between having an uncomfortable week or a comfortable week. And so it's just something to think about. It's not worse or better, but for people who are really scared of needles, then maybe that's a good option for them. I'm going to play with it personally and see how I like it, and I'll let you know, because I feel like that would be a neat experiment on myself. I won't tell my patient to do something I haven't done, right?
All right.
So I always guinea pig myself out.
Last area, and we've gone a little longer than I promised you.
I'm sorry.
I hope you're okay. But
I'm fine.
Last area I wanted to ask you about before I ask you about your programs and things that you do is diet and lifestyle around this, because obviously we don't want to just eat less Doritos or less donuts or less pizza. We want to, if we're going to do something like this, you've talked about obviously a functional medicine approach and taking a sort of a holistic approach. Diet obviously is a cornerstone to that. So what do you recommend that people focus on with their diet and with their physical activity, resistance training, and so forth, while they're on this hormone, or as they start to focus on weight loss and use this approach?
Well, first and foremost, if somebody's eating a really, the standard American diet, and they're not familiar at all with nutrition or what good nutrition is, getting a team on board is so helpful, and not just relying on your medical doctor who's prescribing it, or whatever doctor is prescribing it. Maybe seeking out a nutritional therapist or a registered dietitian who understands functional medicine, or a health coach, somebody just to keep you accountable and help teach you along the way. But yes, eating less garbage, just a smaller quantity of garbage, is not going to help, because you don't have a lot of room in that bag of your stomach. Your stomach is going to tell you it's full a lot faster. And if you're filling up on crummy food, or even just bread or something that is not super nutritionally dense, you're not going to have room for the nutritionally dense food. And my appetite was I'm already a really low appetite gal. So my appetite was crushed in the beginning, and I had to back down. I had to slow my roll a little bit. But I knew very quickly, because my hair started falling out, and I was like, oh, I am missing the macros that I need and the micros. And so making sure that you're really cognizant of your food choices. The first foods you eat really matter, because you want to make them count. You want to make everything you put in your mouth count nutritionally dense food. Prioritizing your protein macros. I find it very difficult to get the 30 grams 3 times a day that I recommend to everyone. I personally have a hard time ingesting that much. So I do utilize some protein powder, some collagen powder, whatever I can to sort of supplement and get it in there. I keeping the high protein snacks on board, hard boiled eggs, beef jerky, things like that, really important. And not just eating crummy food, because if I eat some junk food, that's all the room I got for the day. And you can't really make it up on the backside. If you do, you're going to have a very uncomfortable evening. You can't wait till 7 o'clock at night and be like, oh crap, I didn't get enough nutrition today. I'm going to pound some food. You're going to be up all night with a stomach ache. Exercise. I know a lot of folks are not familiar with strength training, and it really is a skill. So getting proper instruction so you don't hurt yourself is so important. And I know that's not available to everyone, but we have more recent data showing, it used to be like, oh, free weights are better. And that's what I used to preach, free weights over machines. But you know what? Muscle and strength gains, the latest data is showing that machines are just as good. So getting in a gym, a lot of people have access with their health insurance. They don't even know, especially if they're older. They have all kinds of opportunities to get in the gym and get their dues paid for by their insurance. Get in the gym, work the machines, do what you can, but really protecting that muscle is so, so critical. And some folks don't really want to exercise in the beginning, but I usually find that if about 3 months in, they start to want to move. So you know what? Walking, start where you can. Walking, if you're quite heavy, get in a pool and walk. Get yourself moving in any way, shape, or form that you can. And then when you can, as soon as you can, really start to prioritize that muscle. It's one of the things I have found to be the most frustrating with my patients, including my family members, is they won't lift the damn weights. And I keep trying to tell my sweet little mama, I don't want you more frail than you started, right? I'm really trying to protect her muscle at all costs. And the older we get, the harder it is to build muscle and to maintain muscle. And I could go on all day about that, but absolutely prioritize your protein first, then your other nutritionally dense foods. Keep it interesting. Berries, vegetables, fruits, prioritize that. And then, and you know, honey, and get yourself some good, healthy, sweet foods that are naturally derived. And then get your butt in gear and make sure you keep it in gear. And it's a lot easier. There is something about the GLP-1s that seems to induce better energy for most folks. And so they do feel like moving a bit more, and that's great. So take advantage of it.
Okay, great. Yeah, I think that's all excellent advice. And especially when you're losing weight, you have to be really careful to protect your lean body mass. So prioritize protein, as Dr. Tina said, and get in the gym, do some resistance training, because those are the two things that'll help to stimulate that muscle protein synthesis the most.
Absolutely.
Yeah.
Oh, can I add one more thing?
Yeah, please.
Something I have noticed since I've been taking these now for about 6 months, and I'm very careful about not getting too thin, because I always ran thin until menopause and the stress of the last few years. And I'm very, very careful to keep tabs on my breast tissue and my butt. If your glutes are starting to flatten out, you are losing muscle and you are losing vitality. And if your breasts are starting to go, you're losing hormones. So we don't want to get too skinny. I know a lot of women think that that's ideal, but trust me, you're looking at a hip fracture down the line. And I came into this as an avid strength trainer person. So I know what my strength was at, and I'm very careful to try to keep matching that, at least percentage wise, to my body weight. I used to be able to lift X percent to my body weight. So I make sure to keep that there. Long term, you really can continue to drop weight. And I got on the scale the other day and I was shocked. I was 5 pounds less than I thought I was. And my strength is also diminished in the gym. And I was like, oh, no. So that's where you go back to your doctor. That's where that intimate relationship with your doctor comes in, and you have that conversation of like, I am losing strength. You can also buy an inexpensive, they've got really great technology now, these BIA scales that you can get off Amazon. I've got one tagged in my Amazon store, and it's, for $150, you can check your visceral fat, you can check your body fat, and you can check your muscle pretty accurately, or at least see trends. And I think that keeping keen eyes on that is critical. I'll just leave it that.
Great advice. And those are some interesting tips, especially for women with the breast tissue and buttocks. So, excellent.
When it goes flat, you're in trouble. And I don't mean lost, I mean deflated. When everything deflates, it's like, oh, we're losing vitality here.
Okay. Interesting. So, you've got a whole series on GLP-1s on your podcast, Dr. Tina Show. So if you guys want to learn more about this, check that out. If people want to find out about your programs, I think you have a program all about this and do some other things. What's the best place for people to go to find you?
The podcast is great. There's several episodes. They're kind of scattered about. But I've also just created a 4-part video series that takes you through the really most important parts of this. And that can be found at drtina.com/Ozempic Uncovered. And so if you want to have that in the show notes, that's a 4-part series. It takes them into being able to purchase my program if they're interested, but it talks all about it in there. So they can learn more about it through that route. And then I talk about it on my Instagram at Dr. Tina. And then, my podcast is probably the best place.
Okay. Excellent. Thank you so much. This was wonderful. I knew we were going to cover a lot of ground. So Dr. Tina Mowll, thanks for being with us.
Oh, it was so fun. Thank you.
You're welcome. All right. Thanks, everybody.